All right, so chapter 8, pathophysiology. All right, everybody can see the screen okay now? Presentation is up. Excellent. Let me turn off my eraser though. All right. So we talk about how we're integrating comprehensive knowledge of pathophysiology on the major human systems. Like, what's really going on behind that? Remember how I was talking about that reverse pyramid thing about differential diagnosis? And the way I usually, I do this in my EMT classes as well, and it's taking the pyramid like this, right? This being your diagnosis, and this being all the different symptoms, right? So what potentially could be wrong? If I said a patient in altered mental status, you can list off a bunch of different things potentially could be, right? It could be, I'm going to put down DM, sugar, right? Head trauma. I mean, we keep going, right? Trauma related, it could be diabetes, it could be ETOH, it could be CVA, MI, all these different things that potentially could be. And we're going to do all this as the testing field. And this is our diagnosis, looking at differentials. So what can we do to check for an MI? We can do a 12 lead. What can we do to check for CVA? We can do a stroke scale. How can we determine ETOH? Well, we can smell it on the breath, but what if it's fruity? Well, that could be DKA. Okay, well, how do we check for DKA? Check a blood sugar. Blood sugar is normal. Okay, well, could it potentially be, ETOH at that point? Well, patient admits to having, 15 drinks. Okay, that probably could be what it is, right? Was there any trauma involved? Could there potentially be head trauma? Could it be intracranial pressure? We look at all the different testing fields, looking at AEIOU TIPS, that acronym, to help determine altered mental status. What could be causing it? And then looking through all the testing, vital signs, because patients who's hypovolemic, who's hypoxic, those patients can also be altered mental status. So if the SpO2 is 78% and they're altered, we'll give them oxygen. Okay, percentage comes back up, they're still altered. Okay, well maybe it's not a hypoxic deal, maybe it's something else. And we do all these different testings and in the field, and we come up with this differential. And our differential at this point here is where we start our put down T or TX. It's not really treatment, treatments. Now we're going to start doing our treatments, right? But in order to get to all this here, we have to have an understanding of pathophysiology and what's going to happen when we do something. All right. And that's where that comprehensive knowledge comes into play, is what are we doing to achieve our goal in patient assessment? So pathophysiology is the study of the physiology of altered functioning in the presence of a disease. So when the body can no longer maintain homeostasis, a disease may result. What's going on underneath it? So you must understand the ways diseases alter the structure and function in the cells. All right. So cells undergo adaptation when exposed to adverse conditions: atrophy, hypertrophy, hyperplasia, dysplasia, metaplasia as well. Let's go over those more in a little detail here. I just have to close the door really quick. So atrophy is a decrease in cell size due to a loss of subcellular components. Hypertrophy is increase in the cell size, in the size of the cell due to the synthesis of more subcellular components. Hyperplasia is the increase in actual number of cells in an organ or tissue. Dysplasia is an alteration of the size, shape, or organization of a cell. And metaplasia is reversible cellular adaptation in which one adult cell type is replaced by another. All right. So disturbance in fluid balance. We do a lot with fluid balance, right? At the advanced level, we can give fluid like no tomorrow. But we have to make sure we're giving the right amount. All right. So so we'll talk about that here in a second. Changes in fluid and electrolyte balance that disrupt homeostasis can either cause or exacerbate various disease processes. Homeostasis can be upset in several ways, such as excessive output or input of fluids. Right? So the degree of fluid imbalance required to compromise homeostasis and cause illness depends on the patient's size, age, underlying medical conditions, where fluid therapy is a fundamental step of resuscitation, right? So if a patient who's dehydrated, okay, these patients require fluid therapy. But the question is how much do we give? Okay, and that's all going to be based upon different aspects of the patient, age, size, right? So what we're going to do, and I'm going to wait till I have a slide here that I can. I'm going to go back 2 slides just for a minute. Okay, so I have a more white spot to write. It's all going to be based upon size. We have to convert things over, right? We have to know how much fluid that we can give, and everything's run in kilograms. Okay, so let me go back to here. So I have a little more space to write stuff down. All right. So for neonate, okay, we're looking at 10 ml per kilogram. Okay, good number to remember. Okay. Pediatric, 20 mLs per kilogram. All right. Adult, 30 mLs per kilogram. Those are dosaging that you're going to want to remember. Okay, this helps with fluid replacement so we don't overload a patient. So how do we convert pounds to kilograms? Who can tell me? How do we convert them over?
Multiply 2.2.
Or divide by 2.2, right?
Yeah, that's the one.
Right. So that's great. So I'm going to ask you this question here really quick. All right. It's 3 o'clock in the morning. You just got toned out to go to some place in Tamworth because you're on the truck. And you get to a patient who weighs 300 pounds. We'll keep it simple. Quickly tell me what that is right now, divided by 2.2 in your head. Right? It's 3 o'clock in the morning. Who wants to do math at 3 o'clock in the morning, right? Get your calculator out, go through all this stuff. Why don't we make things a little more simple? And that's where we take off, divide by 2, and take off 10%. Okay, so what we're going to do is we're going to take 300 divided by 2 is what? 150? 10% of that on a 3-digit number is your first 2 numbers. So take off 10%, 135 kilos. Okay, someone grab a calculator really quick and do 300 divided by 2.2. See, tell me what it comes out to be. Anybody in the class, just grab a calculator if you want on your phone. Do 300 divided by 2.2 and tell me what the number is.
136.
Okay, so am I pretty close? Are you rounding up? Or is it exactly 136?
It's 136.36,
Okay.
3636.
So 1 kilogram is not going to make a huge difference unless you're dealing with premature babies and you're doing fluid administration with that. But neonates can be 1 kilogram off, and it's not going to hurt them. Yeah, like I mentioned, preemies, everything is measured, including a flush for them. That's more critical care medicine. All right. I have a pediatric that weighs 25 pounds. Divide that by 2. Right? Equals what? What do you guys have for numbers?
12.5.
Okay. 10% is the first number here.
It's 11.5.
So 11 kilograms. Patient weighs 30 pounds. Divided by 2 is 15. Minus 1, 14 kilograms. Do you see how easy that is? Right? If they're 8 pounds, then we just divide that by 2. It's 4 kilos. Okay. If it's a 2-digit number, take off the first number. and subtract that. If it's a 3-digit number, it's the first two numbers, subtract that. That's your 10%. Okay, and that gives you that kilogram, what we're looking for. So I'm going to ask, so I got Sean on the screen now because I can see his picture here. I'm still working on trying how to see everybody. But I'm going to ask you a question, Sean. You ready? A patient that weighs 350 pounds needs fluid replacement. Okay, they're a 40-year-old male. How much fluid are you going to give them? Anybody else can do the numbers too.
So that's 113 kilograms.
So 350, right?
Divided by 2.
Divided by 2 is 175 minus 17, right?
Yeah.
Puts you at 158.
Yeah.
Okay, and we're going to do 30 mLs per kilo. So we're going to times that by 30. We give you 4,740 mLs of fluid. If you're doing hypovolemic fluid replacement. Okay. These are things you guys should be practicing. Throw different numbers out as you're doing this and try to figure out what it's going to end up being. All right. So let's see. Owen, I'm going to ask you a question next. Okay. This is important because we're going to get into fluid therapy and replacement and pathophysiology. You have a 6-year-old female who weighs 50 pounds. How much fluid do you give?
I'm sorry, I'm lost with the math right now.
That's fine. So you take 50 pounds, right? Divide that by 2 is 25 minus 2 puts you at 23 kilos. And you're going to multiply that by 20, gives you 460 mLs of fluid.
Okay.
Okay. These are things you have to be familiar with because when you start getting into burn patients, we're using a modified Parkland formula. And that's all within the advanced scope of practice because it's not a fluid you're going to be administering a patient over the course of 8 hours, over the course of an hour, and over the course of 24 hours. These are all numbers you need to be familiar with. And med math is at the advanced level. Okay. Especially when you start getting into pediatric weight, everything's weight-based in peds. So get used to converting stuff over, right? So I'm throwing these different things at you now. These are the basics. Neonates are 10, pediatrics are 20, adults are 30 mLs per kilo, and we have to convert everything into kilograms, right? That's how we need to make sure we're working that stuff out. That's why when I mentioned here, the patient's size, okay, size would be in kilograms, and the age is going to determine whether or not what number we're going to be utilizing because we have to make sure we meet that homeostasis, and that's the underlying condition potentially causing them to require fluids. Now, that's just the basics of this, okay? Edema is swelling caused by excessive fluid trapped in the body tissue. What we're looking at here is pretty significant edema, and what we're also going to check for is what they call pitting edema, and it's +1 through +4 by pushing your finger in and seeing if it returns back to normal. Okay. With this lady here, she has pretty significant edema in her feet. So because I like talking about pathophysiology, what potentially could be causing this? And we'll get into some of the causes here in a moment. What do you think?
Congestive heart failure.
I heard congestive heart failure. Is that what I heard? I think it was, I'm not sure who said that.
Yeah.
Okay. What specifically, what side of the heart is failing though? That's the important part.
The left ventricle.
Well, the left ventricle would cause pulmonary edema. So what other side would it be?
The right.
The right.
The right side. So if you have pulmonary edema, we're going to see left-sided heart failure. If we have extremity edema, we're going to see right-sided heart failure. Okay. So kind of look at both of those. Think about how the heart pumps, right? Deoxygenated blood comes in through the right atrium into the right ventricle, goes into the lungs, picks up that oxygen, right? That gas exchange, carbon dioxide out, oxygen comes in and goes into the left atrium, left ventricle. So the left side of the heart fails, that fluid backs up into the lungs. If the right side of the heart fails, it backs up through into the extremity. And significant right side heart failure, you might actually see jugular vein distension, right? Because it's coming back in. The veins will start pumping out. Now, not always. I mean, this lady here probably does not have JVD. She needs some Lasix. She needs some fluid taken off. So you might see medications like furosemide, hydrochlorothiazide, things like that might be some kind of diuretic to push that fluid out. But that's where things come in, though. We start talking about fluid replacement. As I said, I'm going to go kind of all over the place, but it's still not all over the place with this. They're going to be taking potential furosemide, right? Well, furosemide is a loop diuretic stimulating the ascending and descending loop, pushing fluid out from the nephron of the kidney, and also doesn't spare any potassium. So now we're peeing potassium out, and we're not replenishing it. It doesn't spare it, right? So now we're pissing out all of our potassium, and that's going to cause more significant cardiac issues. So we have to ask these specific questions. What kind of medications are they on? And we put them on EKG, and we see flattened T waves, right? And we know that patient's going to be hypokalemic. They're going to see low potassium, potentially. Okay, now I know this is a little over your head now, but this will come back to you guys later on in cardiac. Okay, I'm going to give you a little precursor to what we're going to be coming into, because edema is cardiac, most likely going to be a cardiac issue. Now, edema can be caused by burns and things like that too. So here are some causes. Increased capillary hydrostatic pressure, right? Like an allergic reaction or inflammation, venous obstruction, pregnancy, heat stress. I can tell you that when I'm outside in the heat, my hands start to swell a little bit. I can't get my wedding ring off. But when it's cold out, it almost falls off my finger. Okay, because we start picking up fluid. Decrease colloidal osmotic pressure in the capillaries. So this is a decreased production of plasma proteins in patients with liver disease, right? Or severe protein deficiency. Increased loss of plasma proteins from kidney disease or other extensive burns, right? We just talked about that. Burn patients, right? Burn patients are having complete electrolyte imbalance. Okay, this is why it's so important to removing fluid replacement. We'll talk about that in environmental and burns and on the modified Parkland formula, how much fluid these patients are truly going to get. All right. Obstruction of lymphatic vessels can also cause edema. The clinical manifestations of edema can also be local or generalized. In-depth physical assessment and would include auscultation of breath sounds. We have to listen to lung sounds. 8 on the back, 4 on the front, find out where that fluid level is. A good way to put it, they're drowning internally if it's pulmonary edema. Okay. We have to find a way to get rid of that fluid for that patient. And since we're on that, this is how we're going to do it if they can make them their own airway. Promise you that's a P. There. Okay. CPAP is how we're going to push that fluid out. Nitrates is how we're going to remove some of that fluid as long as their blood pressures are maintaining appropriately. Vasodilation makes a bigger container, fluid goes away in the lungs. Definitive treatment depends on the underlying medical condition. Okay, there's a lot of things that potentially could be going wrong here. If I got a patient who has kidney disease and extensive burns, I'm not going to give them nitro, right? They're going to get fluid replacement. The edema is not from a cardiac issue. They're not hypertensive. Okay, so that's what we got to look at. That's where our clinician comes into play, is we're going to provide definitive treatment, but what is really going on underneath? Okay, full set of vital signs, blood pressure, heart rate, lung sounds, blood sugar, right? Capillary refill, pupillary response, all the things we're going to be doing that we remember from EMT school, respiratory rate, heart rate, right? A lot of these things could indicate any type of condition that could cause edema, to looking at the numbers, all right? So isotonic fluid deficit. So decrease in extracellular fluid with proportionate losses of sodium and water is your isotonic fluid deficit. Most common form of fluid loss. Isotonic fluid excess is proportionate increase of sodium and water and extracellular fluid. So the common causes would include kidney and heart failure. Right, we're going to see kidney disease and heart failure as well with this. So deficit versus fluid excess. Do we have too much or do we have too little? So what can we do to find out if a patient is hypovolemic? So we'll say isotonic fluid deficient. What can we do for this patient? How can we tell? They're losing sodium and water. What are some causes of patients losing water?
Sweating.
Okay, and what
Vomiting.
else? What was
No,
that?
vomiting.
Vomiting.
Vomiting and
Diarrhea.
diarrhea, right? What else can make us lose fluid? Burns. Burns can cause dehydration. What else? All right, let's go to the isotonic fluid excess. How do we know if we have too much fluid?
Excessive urination.
Okay.
Edema.
What else though? I heard edema, heart failure, right? Too much fluid, it's got to go somewhere. It picks the least path or least resistance, right? Third spacing, interstitial space fluid, edema, pulmonary edema in the lungs, depending on which side of your heart's failing. Okay, a lot of different causes that could cause this stuff. So the electrolyte imbalance is a sodium regulate fluid balance, which total fluid volume and blood pressure in the human body. Right, we're going to go over this stuff here in a second. These ones up here. Now they're talking about lab work. Okay, these are things you don't get usually until paramedic school, and even still, they don't cover it very high in paramedic school. But you may see these numbers come back to you again. Right, so this also facilitates muscle contraction and nerve impulse transmission. Sodium. Okay, hypertonic fluid deficit occurs due to a disproportionate loss of sodium and water loss. So salt, right? Sodium being removed from the body. All right. There's two different ones. One's called hypernatremia and hyponatremia. Why do they call it Na, natremia? Because the periodic table, okay, and A is sodium. So hypernatremia, hyponatremia. So hypernatremia is a serum sodium level of 146 milliequivalent per liter or higher. Okay. Hyponatremia is a sodium level of 134 or lower. We'll talk about that here in 1 second. Causes of hyper and hyponatremia include excessive sweating and heat during exercise, gastrointestinal loss through vomiting and diarrhea, and inappropriate use of intravenous fluids or diuretics. Okay. We give fluids that have sodium in them, right? So NaCl is normal saline. L is lactated ringers. Each one of those, this one here has sodium. This one has sodium, potassium, chloride, right? All these different electrolytes inside of it. If we give patients too much fluid, that can change it will change these serum level numbers. Okay. We don't want to be too high. We don't want to be too low, especially too low. What happens if your body has very low sodium levels? What can happen? What can be caused by, I should say, a patient who's hyponatremia? And let's just throw a number out there. 117. That's pretty low compared to we look at 134, right? What do we expect to see with a patient who has very low sodium? What do we need to watch out for? One of the biggest
Abnormal,
things
like
we
a
got,
heart rhythm.
not, well, you could have some heart issues. 'Cause remember, you have a sodium potassium pump that helps with the electrical conduction system, right? It helps move that, help pump the heart. But here's the other thing we got to watch out for: patients who have low sodium. And you're going to be called to patients like this in a 911 setting, where they say, respond to this location, doctor requesting transport for abnormal labs. Who has heard that before? I've heard it through county dispatches all the time. Patient requesting transport per the doctor for abnormal lab work. You guys have heard that before? Have been to calls like that before? Yes, no, maybe.
Yes.
Yes. And they tell you, the doctor said my sodium is really low. And they said it was like 120. Are we concerned about that? Prior to you
Yes.
learning about this, would you have been concerned about low salt?
No.
No. This is what's going to happen. Not that. Seizures. Low sodium can cause seizures, right? So if you've got a patient who has a sodium level of 117, 120, those low numbers, right? They're in that ballpark now for having seizures in the back of the ambulance with you. Now, am I saying to call for a paramedic every time you see this? No. I want you to be aware that low sodium can cause seizures in a patient. Get your 12 lead, get a blood glucose if you want to get one of those as well. But the 12 lead is going to be important to kind of see where they sit. Okay, and transmit that to the hospital so the physician can see it, get a print off for the medic if you called for one. Just be aware that seizures could happen with low sodium. All right, let's go to the next one. Another important electrolyte that we have in our body is potassium, and I'll put a little K next to it. Okay, potassium has a positive charge, but potassium is done with a K. Crucial to many cellular functions. The normal serum level potassium ranges 3.5 to 5 milliequivalents per liter. Hypokalemia is a decreased serum potassium. What causes would include decreased dietary potassium intake and absorption, decreased shift of potassium in the cells, renal potassium loss, okay, and extra renal potassium loss as well. Hyperkalemia, or elevated serum levels, causes would be decreased excretion, shifts of potassium from within the cell, and excessive dietary potassium intake. A lot going on here, right? What could cause a patient to be hyperkalemic? I just gave you a couple, decreased, but what type of medical trauma? Make you guys think a little bit here. Nothing you can do in the field as an advanced EMT to fix this, but I want you guys to understand what could cause this. A patient to be hyperkalemic. I'll give you a hint, it has to do with trauma.
Excessive blood loss?
Not excessive blood loss. We'll talk about more of this in trauma, but crush injuries. Okay, crush injuries can cause increased potassium. So one of the things, if you have a patient who's trapped in this crush, get a paramedic there right away, and this is why. We have to push potassium out of those cells. There are 3 things that we carry on an ambulance that can push potassium out of a cell. And I'll let you guys know what those are. Nothing you can do in the field as an advanced EMT, but having an idea of how it works is a good thing. The first one is we can give calcium gluconate, and that'll help push it out of the cell. The second one is sodium bicarb, and the third one is albuterol. Like, well, isn't that for respiratory? It is. It also moves potassium out of the cells, but we have to give 20 milligrams of inhaled albuterol in order to do that. Okay, nothing you guys are going to be tested on, but just having an idea. But crush injuries can cause it hyperkalemia. What can cause hypokalemia? And we just talked about one of them. Lasix, right? These are non-potassium sparing diuretics, right? So if we have a patient who has a very low potassium level or a very high potassium level, and you do an EKG, I'm going to try my best to draw this out for you. So okay, we have our P wave here, QRS. That's horrible. Okay, see that big spike T wave? We call it peak T waves. This would be hyper K. The other one here is your P waves here, QRS. I promise it's a flattened T, but there's a T wave there. It's called a flat T. Okay, that's your hypo. That's your hypokalemia. Okay, so if you do an EKG, you might see these on there. But tall peak T waves would be your hyper, high potassium, low flattened T waves would be your hypo K, your low potassium. But again, what's the underlying cause behind it? Okay, so if I got a patient who's got a crush injury, we're getting IVs, we're trying to give them some fluids, this and everything else going on, get a 12 lead too while you're at it if you can get one, right? Before the paramedic gets there. It just helps if you see spiked T waves, right, for high potassium levels. Also very important too if you're calling for like DART or you're calling for DART or life flight of Maine, because if they have potential for potassium issues, they can't use succinylcholine as a paralytic, right? They can't have that high potassium levels. Another thing with potassium, also to kind of take away from all this as well, is this is also one of your major electrolytes in the cardiac function, the sodium potassium pump. Okay, so if you have issues with your sodium potassium pump, they need to be cardiac monitored either way. So if you have that abnormal lab with elevated or low potassium, put them on a cardiac monitor, get a 12 lead and continuously monitor them throughout your transport. All right, the next one electrolyte would be calcium. The normal serum level for calcium is 8.6 to 10.2 milligrams per deciliter. Hypocalcemia is a decreased serum level, and hypercalcemia is increased. So let's kind of go over this here. So nearly 98% of the calcium is found in the bones and the teeth. This lends strength and stability to the collagen around the substance that also forms the matrix of the skeletal system. This enters the body through the gastrointestinal tract. Remember, our normal levels are 8.6 to 10.2. With hypocalcemia is decreased serum level. Causes would include decreased calcium intake or absorption, increased calcium loss, endocrine disease, and the last one, sepsis. All right, so sepsis can cause low calcium levels. Hypercalcemia is increased serum level, which is caused by increased calcium intake or absorption, endocrine disorders, neoplasms, and also other miscellaneous causes that are out there. So if you got a patient who's septic, we can probably assume that they may have low calcium. What do we carry in lactated ringers? Calcium, potassium, sodium, chloride, right? All these different electrolytes. This is why it's so important that if we're going to administer, have someone who's septic, even if they have systemic inflammatory response, which are two indicators, okay, without any known infection or presumed infection site that turns it into sepsis, right? We can still give these patients LR to help retain that fluid that they need and fix that electrolyte imbalance and meet that homeostasis. All right. Any questions so far? And I have to ask, is anybody lost yet? This is important stuff because it's all going to turn into what you guys are doing for meds later on. I can only see Canon right now. So is everybody else good? Feel free to unmute. Let me know.
Hanging in there.
All right. All right. Let's move to the next one then. So we look at low and high blood calcium levels here. So as far as the low, let's look at this figure, the blood calcium levels. Low blood calcium would increase PTH secretion and calcitriol formation. So the parathyroid gland secretes PTH and increased PTH levels stimulate calcitriol, which is vitamin D3 production of the kidneys, right? So thyroid, parathyroid, the glands can cause low blood calcium, right? Remember that the thyroid gland also secretes calcitonin. So decreased PTH secretion and formation. The PTH formation slows the PTH levels drop, right, which decreases PTH levels, then slow the calcitriol formation. So is there a test that we can do in the field to see what their thyroid levels are? You guys should all be shaking your head no. There isn't. What they're going to do is they're going to do a blood test called the TSH, and the TSH levels, they're going to read those to find out if it's a thyroid issue or not. All right. So the small intestines, if it's low blood calcium, it absorbs more dietary calcium, which increases the intestinal absorption of the calcium and phosphorus. If you have a high blood calcium, it absorbs less dietary calcium. You see no major effect, slightly inhibits calcium absorption. You can read the rest that's there. With the kidneys, as far as renal calcium goes, PTH and God, I can't speak today. Calcitriol increases calcium reabsorption in the kidney, thus decreasing calcium excretion. But if it's elevated, right, there's really no major effect. As far as the bones go, though, right, for people that have decreased calcium, the PTH, they work together to stimulate osteoclast activity, and osteoclasts reabsorb bone, releasing calcium into the bloodstream, right? So you can kind of see how they go back and forth, where calcium actually plays a huge part, which is why we need to make sure we meet that homeostasis kind of like in the middle, right? All right. So let's go over a couple other ones that are here. One being phosphate, which is essential to many body functions, which is a primary intracellular anion. So hypophosphatemia is a decreased level of serum phosphate, which causes would include decreased supply or absorption, excessive loss of phosphate associated with the use of diuretics, or in the patients with hyperparathyroidism, or alcoholism, right? Intracellular shift of phosphorus, electrolyte abnormalities, and abnormal loss of nutrients followed by inadequate replenishment, right? So phosphate is very important. It's essential to many of the body functions that we have. So what can we see? Well, we have to, if they have hyperparathyroid or hyperthyroidism, right, alcoholism, these are all going to be done through our sample history, right? We're going to be asking these questions. What kind of medical history do you have? If they have thyroid issues, they're going to tell you. But you can always ask them, do you have any issues with your thyroid? Oh, yeah, sure. I have hyperparathyroidism. Okay. That's good for us to know because that can cause phosphate to decrease. Electrolyte abnormalities, other than doing some EKG stuff and things like that, really we don't have the ability to run a CBC inside the back of the ambulance, which is a comprehensive metabolic panel. That's going to tell us a lot of our electrolytes. But hyperphosphatemia, so increased level of serum phosphate, would be massive loading of phosphate into the extracellular fluid or decreased excretion into the urine. Okay, they're going to have to do a urine sample. We're not doing this at all in the back of the ambulance. Okay, so again, these are some things we look for. Remember, it's primarily an intracellular anion. The next one is magnesium. Magnesium is 50%, which is stored within the bones, 49% other body cells, and 1% in the extracellular fluid. Magnesium is one of those electrolytes that plays well in all fields, okay? It works well with the positives and the negatives. So the normal range of magnesium is 1.6 to 2.6 milliequivalents per liter. Hypomagnesemia is a decreased level of serum magnesium, which would be caused by diminished magnesium absorption or intake. Increased renal loss of magnesium. Miscellaneous causes such as diabetes, respiratory alkalosis, and pregnancy. Okay, pregnancy, interesting, right? So why would they bring up pregnancy? What can happen with a patient who is pregnant that has low magnesium?
Gestational diabetes.
I heard eclampsia, right? So eclamptic patients would be seizures, right?
Yep.
So patients that are having seizures. So if you have a pregnant female who's having seizures, we can absolutely, paramedics can absolutely give Versed to stop the seizure as a benzodiazepine. This patient really needs magnesium, right? So, but also diabetics can have low magnesium levels as well, and also respiratory alkalosis. Respiratory alkalosis. I think we just covered that. How do we know if someone's in respiratory alkalosis?
End title?
Haha, end title. Perfect. Great answer. But how do we know that it's patient's alkalotic? What scale could we use to figure that? Well, we really can't do it in the field, but what scale do they use for that? So we have end-tidal CO2, which normal range is 35 to 45, right? Then we have the other one is, what is it?
The pH scale.
pH scale. And what's our normal value?
It's 7.35 to 7.45.
Excellent. All right, so 7.35 to 7.45. So if they're in a respiratory alkalosis, I expect the pH to be up or down.
Down. Or no, sorry. Yeah, up.
Up, right? Because we always sit a little alkalotic, absolute being 7.4. Okay, so we're going to see a patient with it's usually an increase of higher than 7.45, and that would be our alkalosis phase. What most likely will we see with an end tidal will be elevated or decreased? Okay, this would be acidic. The higher the pH, the more acidic they are. Okay, so most likely you're going to have a decreased end tidal with an increased pH. You'll see that respiratory alkalosis. All right. So hypermagnesemia, increased levels of serum and magnesium, almost always occurs as a result of kidney insufficiency, all right, kidney failure. So if for some reason, again, I'm gonna go to the next slide here for a second, there's not enough space to write stuff down. If for some reason you go to a patient for abnormal labs to find out their kidneys are not working, okay, there's two lab values that would indicate kidney function, and that would be your creatinine and BUN. Those are elevated. They have kidney issues. Nothing you're going to be tested on, but again, I'll give you a little more extra information. So the lab values of BUN and creatinine would be elevated. All right. So disturbance of acid-base balance. Okay, we just talked about this a little bit in the last class. So a pH is a measure of the acidity or alkalinity of a solution. A pH, lower the pH, the higher the acidity. Okay. So acidosis is an increase in extracellular hydrogen ions, right, which is H plus ions, hydrogen ions. Alkalosis is a decrease in extracellular hydrogen ions. So a disturbance in acid-base balance associated with disturbances of the potassium balance. So let me show you here in the next slide. Respiratory acidosis is related to hypoventilation. Okay. So remember we talked about that end tidal reading before? We're going to see spiked end tidal because they're hypoventilating, which means that the end tidal will be higher than 45. Okay, you have that spike because they're breathing so slow. If they're breathing too fast, the end tidal is lower than 35. Right? So looking at this different range, right? Respiratory acidosis is always related to hypoventilation. So some causes would include airway obstruction, cardiac arrest, overdose of a CNS suppressant drug like heroin, so opiates, submersion, respiratory arrest, pulmonary edema, closed head injury, and chest trauma. Right? Those are going to be your respiratory acidosis. All right, those are more of your causes. But your signs and symptoms of respiratory acidosis include systemic and or cerebral vasodilation, or both. All right. So cerebral vasodilation, headache, lightheadedness, warm flush skin, CNS depression, bradypnea or slow respiratory rate, nausea and vomiting. So I keep going back to that cerebral vasodilation, right? Systemic or cerebral. Cerebral being what? What's cerebral? Your head. So if we have a patient who has significant head trauma, okay, and we see the end tidal is 60, do we want to hypo or hyperventilate that patient?
Hyperventilate.
Okay. We want to breathe them, make them breathe. We want to breathe for them faster. If we see an end tidal of, let's say, 20, what do we want to do? Hypoventilate or hyperventilate?
Hypo.
Yeah, slow it down. If a patient has vasodilation and they're hypoventilating, by hyperventilating the patient or breathing faster, what does that do to the vasculature? Does it make it bigger or does it make it smaller? Think about what we just talked about. Does it make does it make it vasodilate or vasoconstrict by breathing faster?
Constrict.
It constricts. Okay, this is why patients that get intubated, that have head trauma, get RSI intubated. This is how we tell the difference of how we need to ventilate a patient based upon their end tidal. Okay, so you may be put after, let's say, DART or life flight shows up, they RSI the patient, they intubate them, and they say, okay, here, this is for you to do. I'm doing the rest of my work. And they put you as an advanced EMT, right, on the airway. And they're going to tell you, look at the end tidal numbers. Our goal is 35. And it starts going higher and higher, 45, 55, 60. Breathe faster. By breathing faster, we're going to then we're going to start vasoconstricting. If you start seeing the number go lower and lower and lower, okay, then you're breathing too fast for them. So the days of saying hyperventilation is good for a head injury, it's not just good for a head injury. Okay, it's based upon end tidal readings, which is something that you can do as an advanced EMT and looking at that systemic or cerebral vasodilation. Right, that's what we're looking for, is those specific numbers. By doing this, that respiratory acidosis related to hypoventilation, we can change that and get this back to a better range. Okay, remember that 7.4 pH range is absolute looking at respiratory therapy. Okay, 7.4 is absolute. We want to make sure we have the even balance between the sodium bicarbonate, right? That's our HCO3, our bicarb in our system, and our carbonic acids. Okay, this is why it's so important for this. We can fix a lot looking at end tidal CO2 and proper ventilation, and that's an advanced EMT scope of practice. It's a skill that you guys have. All right. So if the patient has increased carbonic acid, additional carbonic acid retaining owing to impaired pulmonary function, if we can just change that and ventilate that patient to a normal range, our pH is going to become better. Formation of additional bicarbonate come into place, and we can start reducing that systemic vasodilation and becoming in more of a homeostasis. Does that make sense to everybody? Did I explain that okay? Do I need to go back over it again? Good time to ask. This is, like I said, this is not going to be a long night, so we have time. I want to make sure you guys understand the things behind this. I'm not just going to cover what the slide says. I want to make sure I go more in depth and putting it into practical scenario. So when you guys get into your ride times, you see this, you're like, oh, Kevin did talk about this. This is how we're going to fix this problem. This potentially could be going on. And that is the clinician side of things that I want you guys to pay attention to. Okay. That's part of being that good clinician. All right. So there are types of acid-base balance. One is respiratory alkalosis, which is associated with hyperventilation. Okay. With hyperventilation, we start seeing decreased end tidal. Metabolic acidosis, which is associated with any acidosis unrelated to the respiratory system. Anything that changes that bicarb, okay, which is your HCO3, the name for it. 22 to 26 is kind of our normal range for bicarb. Metabolic alkalosis occurs due to an excessive loss of acid, right? Patients that are in cardiac arrest will be in a metabolic acidosis, along with being in a respiratory acidosis as well. Okay, so that's what we're looking for there. So I gotta move this over here for a minute. So respiratory alkalosis is associated with conditions that result in hyperventilation, right? So level of circulating carbonic acid becomes reduced. Hyperventilation accompanied by carpopedal spasm is a classic sign of respiratory alkalosis. So if you see those carpopedal spasms, you guys know what I'm talking about with that? Patients that hyperventilate and their fingers start curling in. Almost looks like you're having, almost looks like the boxer, the fingers curl in, their toes start curling in. You start seeing those spasms in the feet and your wrists. That's called a carpopedal spasm. And most likely the cause is going to be respiratory alkalosis. Okay, why? Because they're hyperventilating. And how do we fix hyperventilation? Well, back in the old day, they made you breathe into a paper bag, right? But how do we fix that? Well, first of all, let's measure it. Let's put them on end tidal. Let's look at the respiratory drive. Let's see where their end tidal sits, right? Then if we have to control it, we control it with what? There's two things. One, we can do psychological first aid, PFA. Let's talk them down. Let's control it. The second thing we can do is put a BVM over their face, and every time they take a breath, we ventilate to our best ability. By doing that, we can help control that respiratory drive and bring that back down again. And how do we know we're at the right mark? End tidal, end tidal, end tidal, end tidal. That's how we're going to look at this. Other causes include drug overdose. Okay, drug overdose, fever, right? The brand new EMT, overzealous BVM. Okay, we have the patient in cardiac arrest, or we have a patient in respiratory arrest, and you're ventilating for them. And that new EMT is on there, and he's like, I'm going to save a life today. And boom, they're squeezing, and they're breathing 30 30 times a minute for this patient. And what are we doing to this patient? We're putting him in a respiratory alkalosis, right? So slow the roll, slow it down. Let's work on that breathing. One breath every 6 to 8 seconds. You can probably get away with one breath every 10 seconds, but slow it down, right? Signs and symptoms include diminished level of consciousness, lightheadedness, carpal pedal spasms, all right? Parastasis of the lips and the face, chest tightness, confusion, vertigo, blurred vision, nausea, vomiting, right? Now, metabolic acidosis. Any acidosis related to the respiratory system. Causes would include ketoacidosis, right? So diabetics, aspirin overdose, lactic acid, or lactic acidosis, okay? Excessive alcohol ingestion, which will put them into an alcoholic ketoacidosis, right? Gastrointestinal losses, so diarrhea, things like that. Carbon monoxide poisoning. So signs and symptoms would include vasodilation, CNS depression, headaches, warm flush skin, tachypnea, so rapid breathing, nausea, vomiting, and cardiac dysrhythmias. Let's talk about metabolic alkalosis now. This occurs due to an excessive loss of acid. Rarely in acute condition. Okay, rarely do we see this, but common among chronically ill patients that we might come in contact with. So nursing home patients that are chronically ill, we may see that metabolic alkalosis. So causes would include excessive vomiting, excessive water intake, nasogastric suctioning, excessive intake of alkaline substances, and some signs and symptoms would be hypotension, bradypnea, so low respiratory rate, muscle tremors and cramps, and confusion. Right? These are things you guys need to know. Okay. You have to know the difference between respiratory and metabolic alkalosis and acidosis, how to be able to recognize it, and the causes and signs and symptoms behind it. I just covered like 95% of those with you guys right now. So if you have flashcards, make them, learn them, and know the difference between these two. Because I've been told by people that have taken the National Registry that there are questions based upon the pH stuff and acid-base balance. Okay. So know the differences between them. I do not believe they're going to get into compensated stuff. It's going to be just the basics. Right? We're not talking about compensated. It's more ventilator theory stuff, which you guys are not being trained in. All right. So before we get into cellular injury, it is now 7 o'clock. So why don't we take 10 minutes and we'll come back at 7:14. Take time to digest this stuff that I just talked about, and then we'll start with cellular injury. All right. See you guys in 10. I found a way to see everybody's camera, I think. Let's still make this work. Perfect. All right. So, cellular injury. So there are various processes that can cause cellular injury. And we're going to go over more of these in detail here later on throughout the program as well. So the first one's hypoxia, lack of oxygen. Okay, we can fix this, right? We can oxygenate somebody. They give them oxygen, whether it be through nasal cannula, non-breather, BVM, ischemia, lack of blood supply. All right. Chemical injury, infectious injury, immunologic, so hypersensitivity injury, physical damage, like a mechanical injury. Then we have inflammatory. So the different ways that can cause the cellular injury to occur. So this manifestation occurs at microscopic and functional levels. So the common microscopic abnormalities include cell swelling, rupture of a cell membrane or nuclear membrane, or a breakdown of the nuclear material, such as chromosomes. So the functional disturbances may include inefficient oxygen utilization, intracellular acidosis, toxic waste accumulation, derangement of nutrient metabolization, or dysfunction in one system inevitably affects the other function of other systems. So cellular injury that can be repaired up to a point with proper treatment. So we could do some stuff, but not everything that can be done, right? So it's really all going to depend on patient presentation and what is causing that cellular damage. So let's talk about hypoxic injury first. So hypoxic injury is common and often deadly. It can cause cellular injury, which may result from decreased amounts of oxygen in the air. Okay. So what can pull oxygen away? Like where can we find oxygen deficient areas? Where is oxygen pulled away? Anybody? You guys hear me okay? Give me something. Where can we have less oxygen?
In higher altitudes?
Yes. So high altitude sickness. Okay. So that can cause that to happen. Loss of hemoglobin function. Hemoglobin. What's so important about hemoglobin? What does it transport? Oxygen, right?
Yes.
Right. Good. Let's have some more class interaction here. This is fun. The decreased number of red blood cells. Well, how do we have decreased number of red blood cells? Someone say bleeding. Right? Bleeding. Right? Hypovolemic patients. Patients that are bleeding out. Right? We lose hemoglobin function and we lose our red blood cells. So now we start giving them fluids. What happens there? It turns it into Kool-Aid. Right? We're making Kool-Aid now. We don't want to do that. The patient needs whole blood. Right? So we can stabilize to a certain point, but at some point the patient needs red blood cells to transport oxygen. Right? A disease of the respiratory or cardiovascular system. Give me one big one, one big disease that we come in contact with. Like all the elderly people we come in contact with have this. It seems like
COPD.
COPD. Perfect. That's what I'm looking for. Right? COPD, chronic obstructive pulmonary disease. emphysema, chronic bronchitis, right? Asthmatics, right? So cells that are hypoxic for more than a few seconds produce mediators, which lead to more cell damage. So free radicals are the earliest and most dangerous mediators produced by cells. Can we over oxygenate somebody? Is that bad? Right? Free radicals floating in the system. Yeah, we don't want that, right? That can turn into a lot more issues that we'll come in contact. We'll talk more about that in respiratory emergencies, right? So what's our goal then? What number should we be looking for an SpO2 percentage? I mean, perfect's 100. Should we be shooting for 100 then? I'm seeing Mike shake his head no. And he's correct. No. Our goal is 94 to 99%. We can measure that, right? Can a patient have more than 100% in their system? Yeah. And we can't read it with a normal pulse oximeter. They need an arterial blood gas to find out that number, right? So patients that I have transported, patients that I've done with intubations before, things like that, in the ERs and working and doing ICU stuff and rotations and everything else, patients that come in from EMS that have put them on 100% high flow oxygen are coming in with numbers around 400. We're over oxygenating these patients because once it hits 100%, we can no longer see it anymore. Okay, we stop at 100, but it still goes up higher and higher. So the goal is 99, right? And that's what we look for. We don't want to over oxygenate people. Okay, free radicals get in the system, turns into a very, very dangerous situation. All right. Chemical injury. So the variety of chemical injuries may occur, ultimately destroy cells. Common poisons include cyanide and pesticides. What does cyanide smell like? Just out of curiosity. Anybody
Almond?
know? Almonds. It smells like almonds. So, and from what I've been told in some readings that I've done, there's 50% of the population can smell almonds. Some people, most people, 50% cannot, 50% can smell almonds. So cyanide induces cell hypoxia. Right? Pesticides. How can we tell if someone has a pesticide poisoning? We'll get into more of this later. Just give me something really quick.
Lacrimation.
Yep. Otherwise known as, which acronym can we use?
Sludgeum.
Sludgeum, sludge, or dumbbells. All right. Pesticides. So what pesticides do is they prevent the proper transmission of nerve impulses by blocking the enzyme called acetylcholine esterase, otherwise known as ACH. All right. So acetylcholine esterase. Long-term ingestion of lead leads to brain injury and neurologic dysfunction. Carbon monoxide poisoning prevents adequate oxygenation to the tissues because the affinity has a higher affinity, so it'll stick to hemoglobin and red blood cells and replace it with oxygen. So if you put a patient on a pulse oximeter and you have a reading of 99% and they've been involved in a carbon monoxide type deal, most likely that's going to give you a false reading and they're not 100%. They're not at all. These patients need high flow oxygen to push that carbon monoxide away and then have oxygen attached to those hemoglobin for that oxygen transport. Okay, so how can we measure carbon monoxide? Instead of SpO2, what is it called? So SpCO. So we can monitor that. There's two different things we can use in the field. Is one, we can use what they call an SpCO reading. We can gather from a cardiac monitor. If we have the special cable, we can do SpO2 and SpCO together. And like a Zoll X series monitor will have that ability to read that. Or you get something called a RAD57 monitor, and that can monitor carbon monoxide levels in the blood as well. Okay. Other ones would be higher doses of ethanol, which can produce severe CNS depression and also hypoventilation. So the infectious injury, this occurs as a result of an invasion of bacteria, fungi, or viruses, right? So virulescence measures diseases causing ability of a microorganism. So a depressed immune system also is less capable of fighting off microorganisms. So patients that have low white counts, white blood cells, right? Those are your immunocompromised patients, those or depressed immune system. So patients that are on chemotherapy, right? So if we have a patient who's on chemotherapy, should they be wearing a mask? Absolutely. Should we be wearing a mask for these patients? Absolutely. Put the mask back on. Okay. So when cells are injured, circulating white blood cells are then attached or attracted, sorry, to the site of injury and release pyrogens, okay, which causes a fever to develop. The fever is developing to help fight off that infection. Just keep in mind, the lower the white count, the harder it is for a patient to fight an infection. The higher the white count, right, shows a patient that has an infection. It's trying to fight it off, right? So this is what they're going to gather on what they call a CBC, a complete blood count, which measures your hemoglobin, your hematocrit, white count, and red count. Okay, so if you get called to a patient who has, let's say, abnormal labs with an increased white count, that means that they have an infection somewhere, right? If you go to a residence and the patient says they're on chemotherapy, expect and assume that their white count is pretty much wiped out, right? And then that they can no longer fight off infection. So septicemia is another one, or sepsis, which is a systemic disease caused by the proliferation of the microorganism or related toxin in the blood, otherwise known as bacteremia. So bacteremia gets into the bloodstream, and by becoming infected, what's going to happen is they're going to have widespread vasodilation. If you have widespread vasodilation with an increased cardiac output, what's going to happen to your blood pressure? I'm seeing Jen saying down, right? Your blood pressure is going to start going down. Sepsis is one of the most unrecognized infections that we deal with in the field because some of the indicators are so slight that people miss them, right? So we got to look for that sepsis deal. Sepsis can turn into something called MODS, which is multiple organ dysfunction syndrome. It can also turn into DIC, where you have the clotting cascade gets completely insane, causing significant blood clots within the system. Okay, so this is what sepsis can turn into if not recognized early enough. So we got to make sure we pick up on this. And our treatment for this is going to be obviously antibiotics, which we could not give in the field, at least not at the advanced EMT level, but also fluids. It's something that we can do. So my recommendation is start off with ringers, and what I usually do is I bounce them back and forth, ringers to saline liter per liter. Okay, that way we're not giving too many electrolytes, but enough to be able to maintain homeostasis. Right. So viruses take on the metabolic process of the host cell, and then what they do is they use the cell to replicate. So a virus consists of a nucleic acid core or of RNA and DNA. The viral infection of a host cell leads to decreased synthesis of the macromolecules vital to host a cell. All right, so these are more of our infections. Let's show you the next slide here. So this slide here, many bacteria have a capsule that protects from the ingestion and destruction of a phagocyte. The presence of bacteria in the blood is called bacteremia. We're going to see bacteremia with patients that are septic. Okay. All right. Immunologic and inflammatory injury. So inflammation is a protective response occurring in the presence of cellular injury. Right? Inflammation is good. right? It helps protect it. This can be triggered by a physical, chemical, or microbiologic agent. Signs of inflammation are heat, redness, tenderness, swelling, and pain. If the inflammatory process is severe, systemic effects become evident. So a person feels ill and their body temperature becomes elevated. The bone marrow then accelerates its production of leukocytes, what they call leukocytosis, and the outcome will depend on the amount of tissue damage. There is a test in the labs that they can do, right, that can measure inflammation, and it's called a CRP. Okay, you know, if you write this down if you want to, but patients that have elevated CRPs are going to have it's an inflammation marker. It won't tell you where it is, it just tells you there's inflammation. It's an inflammation marker. So this figure here shows the local systemic effects of tissue injury caused by various different agents, as you can see here on the screen. All right, physical versus pathogenic microorganisms causing tissue image or chemical agent causing a tissue injury. So you have your mediators of inflammation. So you have capillary dilation, which increases blood flow. So if our capillaries dilate, we have increased capillary permeability, so extravasation of fluid. Then we have the attraction of leukocytes, which is migration of white cells to this site of injury. And then our systemic response is a fever leukocytosis. Heat, redness, tenderness, swelling, and pain. Right? So we're increasing blood flow, which can in turn potentially drop blood pressure, right? Increase capillary permeability. So now we have a ton of fluid, inflammation and swelling, and redness, right? You kind of see how this process works, right? So that an inflammatory injury measured by a CRP in the hospital setting will indicate us moving towards antibiotics, depending on what it potentially could be to treat this. Now, why am I talking about all this stuff here? This is the reason behind it. Having an understanding what the emergency departments are going to do will help your treatment plans in the field prepping for that to happen. Right? Sepsis is one of the biggest misses, and I keep bringing this up, misses in EMS from EMT to paramedic level. Little things like a respiratory rate of 24 and a heart rate of 100 are two indicators of systemic inflammatory response with a known or presumed infection site is now sepsis. All right? Would you think anything of it with a respiratory rate of 24 and a heart rate of 100? People miss those little things. You do not have to have a fever to have systemic inflammatory response. A fever of greater than 100.4 or less than 96.8, by the way, cold sepsis is worse than hot sepsis, right? Are indicators as well, along with a MAP of 64 or less and a end tidal of less than 32. And what they're saying now, if you have an end tidal of 28 or less, that's equivalent to having a lactic acid reading of 4 or higher, at least 4 at minimum. Okay. So we're seeing a lot of these things now that talk about that immunologic or that inflammatory injury, talking about that sepsis deal. All right. And why do I keep bringing it up again? Because we miss it. We miss this in the field. Patients that are septic should be getting 2 IV lines, right? If your system allows to. So looking at people that are in this class, I can talk about Lucas for a minute because I know where he works. All right. As an advanced EMT, you can draw labs. Right? We need to make sure we're getting labs. All right. And the paramedics should be drawing cultures in the field because this helps with early antibiotic therapy because that's what they need. All right. Cool. Let's go to the next slide. Right. Injurious genetic factors. So an abnormal gene may develop by mutation of the gene during meiosis, right? Or they could be hereditary as well, or as a result of other causes later in life. So genetic factors that damage cells include chromosomal disorders, premature development of atherosclerosis, and also sometimes obesity. So a lot of these things can also be other factors of the genetic injury genetics. Other physical, nutritional imbalances include obesity, malnutrition, vitamin excess or deficiency, and mineral excess or deficiency. Let's go to the next one here. Other physical agents would be heat, cold, and radiation may also cause cellular injury or cellular death. And then the degree of cellular injury is determined by the strength of the agent and the length of the exposure. So how strong is it and how long have you been exposed to it? You can also break this stuff down. All right, so apoptosis is normal cell death. So genetically programmed into the cells as part of the normal development. Otherwise known as organogenesis, immune function, and tissue growth. So proteins and DNA undergo controlled degradation that allows their remnants to be taken up and reused by neighboring cells. See, they do share. Right? So areas that have undergone apoptotic death do not show any evidence of inflammation at all. Let's see what else. So this can also be activated prematurely by a pathogenic factor, such as cell injury, or the inhibition of the normal course of apoptosis, which allows destructive cellular proliferation. All right. So this shows the process of which cancerous cells develop from normal cells, as you can see here in this. And remember back in the previous chapter about the cell. Okay, this kind of goes back into that. So abnormal cell deaths would be necrosis or tissue death, or a result of morphologic changes that occur following cell death. So what can we do as a provider that can cause necrosis? Tissue necrosis. What can we do? Or let me rephrase the question. What can we do to prevent tissue necrosis? Think about IV therapy. Putting an IV in place and it not being in the vein or the vein blows. What medication do we carry that's very necrotic? What do you think? It can be administered as an EMT, just not in an IV form.
Dextrose.
Dextrose, so sugar. Sugar is very necrotic. So if you give a patient D50, well, nowadays D10, and the line is not patent and it goes into the tissue, it will kill the tissue in that area. Right? So it's very necrotic. So tissue death and necrosis. So yeah, can necrosis and tissue death happen as a normal cell death? Absolutely. Can we be a cause of that if we don't check our lines first with saline to make sure they are patent lines? 100% absolutely we can do this to a patient. All right. Now you took the oath of doing no harm, right? This is negligent, right? If you decide to give somebody and put an IV in place and not check the patency of a line, especially if you're giving something as necrotic as sugar or D10. Okay. Do you see how all this ties in now? Right. So tissue necrosis. So let's talk about shock for a little bit. Hypoperfusion. Inadequate state of tissue perfusion is shock. Perfusion is the delivery of oxygen and nutrients and removal of waste by the circulatory system. So hypoperfusion occurs when the level of tissue perfusion decreases below normal. In response, the body releases catecholamines, right, The two catecholamines, one's a neurotransmitter, the other one is a hormone. What would they be? Think about your sympathetic nervous system. Catecholamines, two things get released. One's a hormone, and one's a neurosympathetic nervous system. Do you guys know what they are?
Epinephrine and norepinephrine.
Exactly. Epinephrine is the hormone. The neurotransmitter is norepinephrine. Those two release, which produce increased strength of cardiac contraction, increased pulse rate, vasoconstriction, and increased systemic vascular resistance. Right? We are going to go more in depth later on this parasympathetic and sympathetic nervous system, and there are medications that you administer at the advanced EMT level that are sympathomimetics. Okay, so you're going to have to understand those. So shock is an abnormal state associated with inadequate oxygenation or oxygen and nutrient delivery to the metabolic apparatus of the cell, results in an impairment of cellular metabolism and inadequate perfusion of the vital organs. All right, we need to make sure that we're perfusing appropriately. All right, so let's go over these types of shock. Let's try that again. All right, so shock can occur as a result of that. So the form of mechanostatic approach, there are two types of shocks that are distinguished. One is central shock, which consists of cardiogenic and obstructive, right? And there's peripheral shock, which consists of hypovolemic and distributive shock, right? So central shock is cardiogenic shock occurs when the heart can no longer circulate enough blood to maintain adequate peripheral oxygen delivery, right? Patients that are in cardiogenic shock usually end up on pressors, okay, like norepinephrine, epinephrine, right, phenylephrine, all these different ones that are out there that are paramedic level medications. So if you have a patient who's experiencing central shock in the field, call for a paramedic right away, because we have medications called vasopressors that can assist with this. We also want to find out the underlying cause. Right? Obstructive shock occurs when the blood flow becomes blocked in the heart or the great vessels. Right? So let's talk about one of the obstructive shocks that are there, cardiac tamponade. Right? As you can see here in this picture, right there, right, you can see the swelling and the discoloration, right? So the figures show cardiac tamponade following a myocardial rupture. So the left side is a distended pericardial sac, and the right side is a pericardial sac open, showing clotted blood surrounding the heart, which compress the heart, preventing filling of the right ventricle in diastole. So you guys can see the picture differences. So you've cut that open, now you can see it, right? Cardiac tamponade is found by a specific triad. What is that triad called? And give me the three things that they look for. This is basic level stuff.
Was it Beck's triad?
It is Beck's. So now, since Luke got that one right, somebody else give me the three things that are there behind it. What are the three things we look for?
Hey Kev, I'm not sure if it's blocking everybody else's screen, but where you have your view of our cameras is covering up half the slide.
Oh, you guys can actually see that?
I can. I don't know if that's, yeah, there you go. Now you're.
Well, my apologies. I didn't think you guys could actually see that in the corner. How about now? Is that better?
No, yeah, that looks better.
All right, I'm gonna move this over here then. I won't be able to see the pictures. I didn't think you guys could actually see those. So my apologies for that. So we have cardiac tamponade. There are three things that we can look for to diagnose cardiac tamponade, and Luke got it right. It's Beck's triad. What are the three things? What is Beck's triad?
muffled heart sounds, now pulse,
Yeah, there's one.
narrowed pulse pressures,
Yeah, there's two.
and the distended neck veins.
Yeah, so JVD. Yep. Just the neck veins. Those are the three things you look for to diagnose in the field cardiac tamponade. Can you fix that in the field as an advanced EMT? No. What needs to happen with this? It's something called a pericardial centesis. They stick a big long needle into the pericardial sac and they pull the fluid out. Okay, so nothing that we're going to be doing in the field. All right, next slide. How about this? This is a aortic dissection. Okay. This illustrates showing a thoracic aortic dissection. So in A tear in the ascending aorta causes proximal and distal dissection. Right. And then the one that's here in the descending aorta causes extensive distal dissection. So you can see the tear here. Okay, this is the tear causing it to dissect. So blood getting in the lining on the outside here, causing that to widen. All right, there are different types of dissections using the DeBakey scale, and we will cover more of that in cardiac emergencies. Okay, I'm not going to get too in depth in this right now. Right, so the way the aorta works, as we can see here, these are our great arteries, the brachiocephalic, the left common, and the left subclavian arteries. So we have our ascending aorta. This right here is the aortic arch, which gives birth to the three great arteries. It goes down into the descending aorta. As that drops down, it goes into something like this here. Okay, these go to the renal arteries, and then that will continue down. I'll draw a picture over here for that. That'll continue down and then branch off like this. I'll just draw this like this really quick. That's what the aorta kind of looks like, right? So ascending aortic arch, great arteries, descending renal arteries, femoral arteries. All right, looks like a person walking around with a big head, like a hooked head. But that's how the aorta looks like, okay? Also, on average, the size of diameter of a quarter is that's how wide that aorta is in diameter, but the size of a quarter. So any question on that at all? Good? All right, peripheral shock is hypovolemic shock, circulating blood volume being insufficient to deliver adequate oxygen and nutrients to the body. So exogenous and endogenous are the two types of the hypovolemic shock. And distributive shock is a widespread dilation of the resistant vessels, capacitant vessels, or both for distributive shock. So if we see widespread dilation, what type of shock would that be? What would be a distributive shock? Someone give me one. Anybody?
Like septic shock.
Yeah, sepsis. That was horrible. That's a little better. My pen wasn't working correctly on the screen. All right, moving forward. So anaphylactic shock is a histamine and other vasodilator proteins that are released on exposure to an allergen. All right. So otherwise known as anaphylaxis. Septic shock is a result of widespread infection, and neurogenic shock results from spinal cord injury. So as we'll show you on the next slide. right? There are different receptors in the body called His or H receptors or histamine receptors. There's 3 of those, H1, H2, H3, right? And as a paramedic, we have a medication that's a histamine blocker, and that's Benadryl. All right. I wish it would come down to the advanced level. I'm surprised it hasn't yet because it's very simple to give, either 25 to 50 milligrams. All right. So, but it's given IV, given IM as well, intramuscular. But it is a histamine. Histamine release causing and other vasodilator proteins causing that vasodilation. What medication do you carry as an advanced EMT that can help with anaphylactic shock other than Benadryl, which we do not carry?
Epinephrine.
Epi.
Epi. What is your dose for adult?
0.3.
You used to saying that 0 in front of it, okay? And what's the pediatric dose?
0.15.
Okay. Perfect. All right. Next slide then. So as you can see here on the normal vessel versus a dilated vessel, so more blood flow causing absence of sweating and loss of body temperature control and spinal cord. This is your spinal shock. But having that dilated vessel will then in turn lower your blood pressure. Okay. By dropping your blood pressure, your heart is going to pump faster, increasing the heart rate. We started seeing signs of shock. So most types of shock are characterized by reduced cardiac output, circulatory insufficiency, or a rapid heartbeat. So to determine the presence of absence or of shock, evaluate the presence and volume of peripheral pulses and assess end organ perfusion and function. So we look at modeling, pallor, peripheral or central cyanosis, and delayed cap refill may be signs of presence of shock. All right. The next one here is decreasing levels of end-tidal CO2 are an early indicator of shock. Early indicator. Before you start seeing the modeling, pallor, peripheral, and central cyanosis and all that, end-tidal is an early indicator of shock, and it will start dropping. How important is end-tidal? You guys should be telling me it's very important. Okay, we need to be able to monitor perfusion status. All right, so multiple organ dysfunction syndrome, or MODS, M-O-D-S, all right, is a progressive condition that occurs in some critically ill patients. So concurrent failure of 2 or more organs or organ systems that were initially unharmed. Respiratory, hepatic, renal, hematologic, neurologic, and cardiovascular systems are surveyed in diagnosing MODS. So the overall mortality rate varies widely depending on the underlying etiology and ensuring diagnosis and treatment. So primary MODS is a direct result of an insult, such as a pulmonary contusion. Secondary MODS occurs when injury or infection triggers a massive systemic immune, inflammatory, or coagulation response accompanied by the release of toxins, right? Coagulation response, DIC. Okay. Secondary MODS is a slower, more progressive organ dysfunction. Right. So we look for that inflammatory systemic immune, massive systemic immune as well. So all those together could be triggered by sepsis or any kind of inflammation or infection. So the body's self-defense mechanism is the immune system includes all the structures and possesses associated with the body's defense against foreign substances. So anatomic barriers would be would decrease the chances of foreign substances invading the body, like our skin, hair, and the upper and lower respiratory tracts, like cilia, and also acid in the stomach. So there are different mechanisms that we have that can help fight off that foreign substance. But once it breaches that, then we have the potential for becoming sick. And that's where the immune response starts working. So the body's defense reaction to any foreign substance is directed against invading microbes, foreign bodies, and abnormal cell growth. The innate response starts first and is then reinforced by more specific acquired responses. So components of the cell wall then activate the complement system. So chemotaxins attract leukocytes from the circulation to help fight the infection. Right, this complement cascade ends with the formation of a set of proteins called the membrane attack complex. Right, and now we can measure a lot of these here. Well, they can measure a lot of these here, looking at a comprehensive metabolic panel as well. So the type of immune system cells would be basophil, eosiophil, neutrophil, monocyte. Let's see. Lymphocytes, macrophages, mast cells, plasma cells, B cells or B lymphocytes, helper B cells, memory B cells, killer T cells, and T cell lymphocytes. So naturally, immunity is a nonspecific cellular and hormonal antibody response that operates as the first line of defense against a pathogen. Right? So passively acquired immunity is the receipt of performed antibodies to fight or prevent infection. The primary or initial immune response takes place during the first exposure to an antigen. Remember, an antibody binds to a specific antigen. All right, immunogens is an antigen capable of generating an immune response. A hapten can be combined with an antigen to initiate a specific antibody response in its own at a later time. In humoral immunity, B cell lymphocytes produce antibodies called immunoglobulins. So B cells are then born in the bone marrow and must first be activated to produce any type of antibody. So this shows how antibodies work here. Antigen antibody combined to form an antigen antibody complex, as you can see, working its way right down through. Complex complement activation, precipitation, angulation, and then neuralization. So those come right down to the very bottom where it says bacterial cells swell and they start to burst. Inflammation, which attracts white blood cells, causes histamine release. And then you have phagocytosis, right? So a lot of this stuff here all plays in together, causing this immune response and this widespread infection. So antibodies make antigens more visible to the immune system in 3 ways, right? One is antibodies act as opsoins. So opsonization is the antibody that coats an antigen to facilitate its recognition by immune cells. Number 2, antibodies causes antigens to clump for easier phagocytosis. And number 3 is antibodies bind to the inactive and some toxins produced by bacteria, right? The cell-mediated immunity is characterized by the formation of a population of lymphocytes that can destroy foreign material, right? The subgroup of T cells would be killer T cells, helper T cells, suppressor T cells, memory T cells, and lymphokine-producing cells. So the way to remember this here is that the cell-mediated immunity that's characterized and the lymphocytes that destroy are considered T cells. So anything with a T cell is like a destruction type cell, right? So you'll see that probably on one of your exams or quizzes coming up. This illustration here shows the B cell activation. So the immunocompetent B cells are stimulated by the presence of an antigen, producing an immediate cell called a lymphoblast. The lymphoblasts divide, producing plasma cells and some memory B cells, and memory B cells respond to subsequent antigen encroachment, yielding a rapid secondary response. Right. This illustration here shows the interaction of cell-mediated and humoral immunity. The macrophage presents process antigen fragments to the T lymphocyte. So the B lymphocyte processes the intact antigen and then displays fragments of the same antigen on its cell membrane. The T lymphocyte, remember destruction cells, which has responded to the same antigen, stimulates the B cell lymphocyte to proliferate, mature into plasma cells, making an antibody. Right, and these illustrations here show the general structure of an antibody. Note that the immunoglobulin, or G or IgG, is a monomer. Right, it's one molecule. Immunoglobulin M, or IgM, is a pentamer. So it's a cluster of 5 antibodies and is effective in combining with foreign antigens. Also note that the antigen fits exactly into the antigen binding site. If it did not, it would not be able to bind. So they have to be able to fit together. It's like a puzzle, right? If it doesn't fit, it doesn't work, right? So antigen binding sites therefore have different structures depending on the antigen to which they are designed to bind to, right? As you can see up here in this section here. If this does not fit into here, then it's not going to start that immune response. It has to meet together. Those are considered binding sites. So for the inflammatory response is an inflammatory reaction and immune system response are independent processes that occur simultaneously. Most common causes of inflammation are infection and injury, right? So we look for that infection, fever, right? Any kind of potential septic infection as well. You got to find that source. Okay, it could be internal, it could be external, like a perforated bowel obstructions can turn into become infected, versus just a paper cut, right? Any kind of inflammation or infection where the injury site or medical site could be. An acute inflammatory response involves vascular and cellular components. So during inflammation, mast cells degranulate and release a variety of substances. After degranulation, mast cells are release vasoactive amines. So mast cells synthesize leukotrienes and prostaglandins. So the different plasma protein systems are called, these are the different systems, the Kinnin system, the coagulation system, and the complement system. Right. So the cellular components of inflammation, the polymorphonuclear neutrophils, or PMNs, arrive at the site of tissue injury. So this process involves 2 major stages, right? First one is intravascular phase, where leukocytes move to the sides of the blood vessels and attach to each endothelial cell. The extravascular phase is the leukocytes travel outside the blood vessels into the site of inflammation and kill organisms, right? And the cellular event sequence is margination, activation, and adhesion, transmigration, and then chemotaxis. As far as cellular products of inflammation, cytokines are produced products of cells that affect the function of other cells. So monocytes release monokines, lymphocytes release lymphokines, and then interleukins attract white blood cells to the site of an injury and bacterial invasion, right? So this is starting to fight off that infection to bring those white blood cells in to help start that process of fighting off the infection. We'll start seeing patients get fevers, and also other kinds of responses like tachycardia. They become a little tachypnic, right? So interferon is a protein produced by cells when they are invaded by viruses. Lymphokines stimulate leukocytes. Macrophage activating factors stimulates macrophages to help engulf and destroy foreign substances. So now we're trying to fight off that infection. Migration inhibitory factors keep the white blood cells at the site of the infection or injury until they can perform their designated task, and that is to kill that infection. So we start seeing T cells come in, those basically destructive cells to help get rid of that infection within the system at the cellular level. All right, so injury resolution and repair. So normal wound healing involves 4 steps. 1, repair of the damaged tissue. 2, removal of the inflammatory debris. 3, restoration of the tissue at the normal state. And then number 4 is regeneration of cells. So wounds heal primarily by primary or secondary intention. 1, the primary intention occurs in clean wounds with opposed margins. Secondary intention occurs in large gaping or infected wounds. So, right, so like little paper cuts, that's the primary intention. Very easy to clean, very easy to take care of. Your massive lacerations with tissue hanging out, everything else, those are going to be your secondary intentions. Those are your large gaping infected wounds. All right, so other things to think about too are like bed sores, things like that, ulcers, like stage 1 through stage 4 bed ulcers, things like that. Factors that lead to dysfunctional wound healing may also be local or systemic. So local factors include infection, inadequate blood supply, or foreign bodies, where systemic factors include inadequate nutritional intake leading to insufficient levels of collagen. Back in. Anything that interferes with the epithelialization or wound contraction, hematologic abnormalities, diabetes, AIDS, and use of corticosteroids. The chronic inflammation response, usually caused by an unsuccessful acute inflammatory response associated with infiltrate like pus containing monocytes and lymphocytes, and usually involve tissue destruction and repair or scar formation. This figure here shows that inflammatory response. All right, let's go to the next slide here. So hypersensitivity, which is a response of the body to any substance which the patient has increased sensitivity, like that allergic reaction, right? So allergy is a hypersensitivity reaction to the presence of an agent. So autoimmunity is the production of antibodies or T cells that work against the tissues of one's own body. So if someone is allergic to strawberries and they eat strawberries, they start that allergic to anaphylactic reaction. So types of hypersensitivity reactions, one is a type 1, immediate hypersensitivity reaction. Those are the ones that go into full-blown anaphylaxis, which occurs in a response to a stimulus within a degree of severity will vary, right? Another thing you may also see as well is what they call angioedema, and angioedema is swelling of the tongue. Type 2 is a cytotoxic hypersensitivity reaction where cells are destroyed by the complement fixation of other antibodies. A type 3 is a tissue injury caused by immune complexes, which may be systemic or localized. Systemic form of serum sickness, which results in a large single exposure to an antigen, or a localized form is an arthritis reaction. A type 4 is a delayed cell-mediated hypersensitivity, where you have 2 subtypes, delayed hypersensitivity and cell-mediated cytotoxicity. This is the type of process of a type 1 allergic reaction. So the antigen enters the body, plasma cells then synthesize and release large amounts of IgE antibodies, as you can see here. The IgE antibodies then bind to the mast cells located in many body tissues. Then you get that, this is a sensitization stage. And you go into the secondary response where the same allergen then enters the body, that antigen. Allergens combine with IgE on the mast cells, triggering release of histamine. Those are your H receptors releasing histamine from the mast cell. So histamine and other chemicals being released. Histamine then stimulates dilation of the blood vessels, causing fluid to leak out, which then stimulates the release of copious amounts of mucus and causes contraction of the smooth muscles in the bronchioles. All right. we start seeing that contraction, then we start hearing that wheezing of the bronchioles, right? Now the patient starts to wheeze. You start seeing urticaria. You start hearing respiratory distress, decreased oxygenation. These patients need Benadryl, they need epinephrine. All right, other things you can utilize for this is bronchodilators like albuterol to assist with this as well. So what's happening here is you're seeing that fluid pours out of the capillaries. Mucus is now copiously released, causing that bronchoconstriction. You can't hear lung sounds very well. They no longer can breathe. And the small respiratory passages become constricted. So we have to vasoconstrict, we need to bronchodilate, and we need to stop histamine release. You can do 2 of the 3 of those. Epinephrine, vasoconstricting, albuterol, bronchodilating, right? And calling for ALS care for a paramedic for histamine blockage with Benadryl. All right, next slide. So the immune system targets different molecules depending on the type of hypersensitivity reaction. An allergic reaction is a target of an antigen or allergen. Right? In autoimmune reactions, the target is a person's own tissue. Right? So SLE being one of them, type 1 diabetes mellitus, rheumatoid arthritis, Graves' disease, right? Are all different autoimmune diseases. You may see that pop up again. Right? Immune deficiencies, right? Body's immune system is inadequate and resistance to infectious diseases is decreased. This can be congenital or acquired. Congenital immunodeficiencies are patients that have inherited defects that involve lymphoid stem cells. What they call an acquired immunodeficiency. Other nutritional deficiencies may depress bone marrow function and diminish white blood cell development. So if we're not developing white blood cells, we can't fight off infection. This can be caused by trauma, right, or treated induced, right, which would be your immunodeficiency is caused by like medications like chemotherapy. Replacement therapy is also available for immunodeficient patients. I'm gonna plug in my phone. It's almost dying here. That's my hotspot for this, so I don't want to. Right. Almost there. Almost done. So genetic, environmental, age-related, and sex-associated factors can also contribute to disease as well. So controllable versus uncontrollable risk factors. Uncontrollable factors such as genetics and race influence the development of diseases. We can't control that. Many other factors such as smoking, drinking alcohol, inadequate nutrition, lack of physical activity, and stress can be controlled. So the risk of particular disease often depends on the person's age. In some cases, sex is related to the risk of having certain diseases as well. So the analysis of disease risk involves consideration of a disease rate and disease risk factors. So casual factors, risks include that directly cause a disease to develop. Non-casual factors, risk factors that are associated with a disease but not a direct cause. So all studies of a disease should be considered the incidence, prevalence, and mortality of that disease itself. Right. So risk factors, age, and sex differences often interact with this. So a common familial diseases and associated risk factors. So a true genetic risk is passed through generations by inheritance of a gene. Diseases with a familiar tendency seem to cluster in a family group, despite the lack of evidence of heritable gene-associated abnormalities. So immunologic diseases are caused by hyperactive or hypoactive or activity of the immune system, as we can see in this picture here, this diagram. So what you're looking at here shows the pathogenesis of an allergy. So first, the exposure to the allergen induces formation of specific immunoglobulin E, which is IgE antibodies, in susceptible patients, which then bind to mast cells and basophils. Subsequent exposure to the same allergen leads to antigen-antibody interaction through activity of memory cells, liberating histamine and other mediators from the mast cells and basophils. These mediators induce an allergic manifestation, right? So all this is going on inside the body, right? When you have these different pathogens or pathogenesis of the allergy getting into your system, right? Getting very close to the end. We have 10 more slides. All right, so cancer describes the pathology associated with malignant growths, right? So neoplasms in various anatomic areas. Prognosis often depends on the extent of its spread, so metastasis, and the effectiveness of the treatment. So a major risk factor associated with lung cancer is cigarette smoking. Breast cancer is the most common type of cancer among women, right? And colorectal cancer is the third most common type of cancer in men and women together. Diabetes mellitus, which is one of the most significant endocrine diseases associated with partial insulin secretion or total lack of insulin secretion by the pancreas, right? So ketoacidosis, prone, which is type 1, or insulin-dependent diabetes, or non-ketoacidosis prone, type 2, or non-insulin dependent diabetes. And we'll get into HHNC and all that kind of stuff when we start talking about the endocrine system and the differences. Hematologic disorders or hemolytic anemia is characterized by increased destruction of red blood cells. This disorder has a number of causes such as Rh factor blood transfusion reaction, a disorder that an immune system, and exposure to bacterial toxins or chemicals such as benzene. Hemophilia is an inherited disorder characterized by excessive bleeding. One of the blood clotting proteins necessary for normal blood coagulation is absent or present in abnormally low amounts. These are your different factors. Okay, when we get into bleeding disorders later, we'll talk more about the different factors. So hemochromatosis is an inherited disease in which the body absorbs more iron than it's needed. So cardiovascular disorders, again, we'll cover more of this when we get into cardiovascular injuries, but a cardiomyopathy, which is a disease of the myocardium, a mitral valve prolapse, coronary heart disease, hypertension, and stroke. All right, so these are other common factors for familial disease. This illustration here shows the comparison of a normal cardiac function with malfunction characteristics of the hypertrophic cardiomyopathy. Right. So in the figure A, let me just put this down here. All right, this is A, this is B. All right, so A is a normal heart illustrating non-obstructed flow of the blood from the left ventricle into the aorta during ventricular systole. Right, so you can see how it's passing through right there. Right, a hypertrophic cardiomyopathy illustrates obstruction outflow of the blood from the left ventricle by hypertrophied septum, which impinges on the anterior leaflet of the mitral valve, right? As you can see there, right? You can see how it's being impinged. It's very narrow. So some other common things like that we could cause, like the cardiomyopathy, it could cause, that will cause that would be, trying to blank on a minute. Strep throat. Sorry, I didn't think about that for a minute. So strep can actually cause patients to have a cardiomyopathy later on down the road. That infection can lead right to the heart. If we have someone in pericarditis, so an inflammation of the pericardium, what is one of the most common causes of that? What is one of the more common causes of pericarditis? Since we're talking about cardiac really quick. Any thoughts? Anyone? Hearing nothing. Tooth decay. Your mouth is a cesspool of disease and dirtiness. So if you have tooth decay, it can get directly into your system, causing pericarditis. To diagnose pericarditis in the field, you're going to see basically what look like a global heart attack or ST elevation in all fields. It almost like a complete massive MI, but that's pericarditis. We'll talk more about that in cardiology. I thought I'd just throw that in there as a little tidbit of information. All right, renal disorders, gout and kidney stones. All right. As you can see here, measured in centimeters, this is one of your kidney stones here. Kidney stones, otherwise known as renal colic. The best medication for this is Toradol, right? Which will be coming to an advanced EMT at some point in time in the future. But 15 milligrams of IV Toradol or ketorolac, which is a high-powered NSAID, reduces that inflammation. Because that kidney stone is trying to get through that nephron, trying to get through, and it keeps bouncing off the kidney, the ureters, causing significant inflammation and pain. And believe it or not, this will drop some of the largest people. A small little stone. All right. Gastrointestinal disorders like a malabsorption disorder, lactose intolerance, ulcerative colitis, Crohn's disease, peptic ulcer disease, gallstones, and obesity. So a body mass greater than 30 kilograms. Or greater than 30 kilograms. My God, I can't think of what this is today. But a BMI of greater than 30. All right, neuromuscular disorders like Huntington disease, muscular dystrophy, MS, Alzheimer's disease are some neuromuscular ones. In the psychiatric disorders, some common psychiatric disorders have familial or genetic components like schizophrenia or bipolar disorder. Some other stress and diseases. Stress include a wide range of strong external stimuli, physiologic and psychological, that may cause a physiologic response. So physiologic stress is a change that makes it necessary for the cells of the body to adapt. All right, so concepts related to physiologic stress include stressors itself, its effect in the body, and the body's response to the stress. So general adaptation syndrome, there are 3 stages to stressors, physical and emotional. Stage 1 is called alarm. So the body reacts to the stress first by releasing catecholamines. Stage 2 is resistance and adaptation. So the body adapts to stressors primarily by stimulating the adrenal gland to secrete glucocorticoids and mineralocorticoids. So the anterior pituitary releases adrenocorticotropic hormones, so ACTH, and endorphins are then released. Stage 3 is exhaustion, where the adrenal glands become depleted, decreasing the blood glucose levels, resulting in decreased stress tolerance, progressive mental and physical exhaustion, illness, and collapse. We're going to call that ACTH from now on because that can be a hard one to pronounce at times. So your hypothalamus and your pituitary gland, as you know, is here, the adrenal gland, kidney, and the medulla and the cortex. So as you can see, in the orangish arrow, so the first one here, all right, this is your pituitary adrenal axis. The sympathoadrenal pathway is the one in the pink. So the nerve signal sends to the medulla, which then initiates adrenaline or epinephrine. That hormone is now released, increases in heart rate, breathing rate, and blood sugar, right? ATCH through the medulla and the cortex releases the glucocorticoids, which increases in access to energy storage. Body metabolism starts to speed up, right? This is your fight or flight response, right? And when you start seeing this, what neurotransmitter is also being released in this, and what is this? What part of the autonomic nervous system is this? So first, give me the autonomic nervous system. Which section of that is this? The fight or flight response is which one?
Sympathetic nervous system.
Correct. And what neurotransmitter is released again?
Norepinephrine and epinephrine.
Perfect. So neurotransmitter and hormones. Right. Right. So stress triggers secretion of the adrenocorticotropic hormone and cortisol. We'll talk about cortisol a bit later on. Cushing's syndrome. You heard of that before? Not Cushing's triad. That's different than Cushing's syndrome. Okay. So Cushing's triad is intracranial pressure increase. Cushing's syndrome, otherwise known as moon face, like that over swelling of the face, is a overproduction of cortisol. Right. So that's another thing that you might see as well. Right. So know the difference between those two. If you write down Cushing's, you put down which one you're talking about. And to finish up here, the effects of chronic stress, the hypothalamic pituitary adrenal axis controls reactions to stress. Continued stress leads to the loss of normal control mechanisms of the hypothalamic pituitary adrenal axis. Adrenals continue to produce cortisol, which exhausts the stress mechanism, leading to fatigue and depression that interferes with the serotonin activity. Right? So a consistently high cortisol level suppresses the immune system. Right? So we're talking about that increased cortisol, Cushing's. Right? So effective coping mechanisms can help a patient improve the immune system response. So how do they cope with what's going on? Right? So let's see here. Before we go, I'm going to bring up I did not want to bring that up. Let's see. Where is it's right here. We'll do these really quick. I wanted to start adding these into this to kind of test your knowledge a little bit and see how things worked. All right. So let's finish up with this here, and then we'll call it a night. You guys see that okay? It's very yellow. All right, let's do some case studies, which means I need you guys to unmute when you are and participate. All right, you are complaining to your partner about how taking a pathophysiology review class has nothing to do at all with being a paramedic, advanced EMT. When you are called to a local dialysis center for an unknown medical emergency, you are met by a patient care technician who takes you to Mrs. Jensen, who's a 67-year-old woman who appears to be in moderate distress. The nurse caring for the patient states that 30 minutes into dialysis, the patient's blood pressure dropped to 86/44, and she became short of breath. You guys got that so far? All right, let's go to the next one here. They immediately stopped therapy and called 911. This occurred approximately 15 minutes prior to your arrival. The nurse further mentions that the patient has a fever of 102.4. When questioned, the patient tells you that she missed her last dialysis session because she was not feeling well. She admits to having malaise and a fever for 3 days. She further complains of pain in her right forearm at the site of the dialysis shunt and slight shortness of breath. The patient denies experiencing chest pain, nausea, vomiting, abdominal pain, or dizziness. All right. So, number one, what are some of the functions of the renal system? This is for you guys to answer.
It releases adrenaline for those fight or flight times.
Okay. What else?
It eliminates waste from the body.
Okay. What else we got going on?
Regulates the pH in the blood.
Okay. Can they have a part in blood pressure control?
Yes.
Yeah.
Yes, blood volume.
Okay. So let's see if we can
Electrolytes.
add some of this here. So it definitely rids the body of waste products such as urea, nitrogen, and creatine. Creatinine. The kidneys also help regulate electrolytes in the body, including magnesium, calcium, sodium, potassium. In addition, the kidneys play a major role in acid-base balance of the body, which I think we all hit, right? So as they excrete or reabsorb hydrogen ions in the blood, because of the renal management of fluid and electrolytes, the kidneys also have some part in blood pressure control. So does renal disease affect other organ systems? Yes or no?
Yes, it does.
Yeah.
So renal failure, okay, remember they have to have dialysis now, their kidneys are no longer filtrating, can have considerable effect on the body systems because of the kidneys' role in regulating fluid balance, which we just talked about, and thus perfusion of the organs, as well as their role in acid-base balance and electrolyte management, which also impacts other organs. That's why it's so important, dialysis. We talk about,
Yes, it
we talk about, oh my God, we're doing transfers, we're doing the renal roundup, right? That's great. But those are some of the sickest people you're going to see because they can no longer regulate what we just talked about. So now their lab values way out of whack. They can't control their blood pressures. They missed a session because they didn't feel well. So now their body's fighting an infection. They have a fever, right? As far as IV access goes, where the fistula is located, you can't put a restriction band on it. You got a really sick patient in front of you. Things that some providers will BLS because it's just dialysis. Well, there is no such thing as just dialysis, right? When your kidneys can't function, now that you guys have an understanding of pathophysiology, these patients are truly sick and cannot regulate. And if you can't regulate, they can die. All right. So great job on the answers. All right. You ask your partner to place the patient on 100% oxygen via non-rebreather mask and get a set of baseline vital signs. While you begin to question her regarding her current illness and past medical history, the patient tells you that she has end-stage renal disease and requires dialysis every other day. She was unable to make it to her last appointment because she did not feel well and had no way to get there. She did not call her physician, stating that she thought she could shake off this bug. She's been taking acetaminophen every 4 hours for the fever and the pain in her forearm. Her past medical history is significant for hypertension, and she had an MI back in 2003. She does have congestive heart failure as well. Daily medications include captopril, low-dose aspirin, and nitroglycerin as needed. Right, your assessment of the patient shows a respiratory rate of 32, heart rate of 116, blood pressure 84/40. ECG monitor at the dialysis center shows sinus tachycardia with occasional premature beats. And you note that the T waves seem to be tall and pointed, which the nurse tells you is a sign of too much potassium in the blood. Remember, we talked about those tall peak T waves, right? The oxygen saturation with the patient on a non-rebreathing mask is only 94%. What problems should you monitor in this patient?
End title.
Okay, end title. What else? First and foremost, what's the bad thing here?
Hyperkalemia.
Now, we really can't fix much of that right off the bat. What's the big issue though?
This patient is like severely septic.
Not necessarily septic. She's got some indicators, so you're not wrong. There's indicators of her becoming septic there. Okay, but sepsis is a diagnosis, right? What do we need to fix?
Blood pressure?
Yes, she's hypotensive. If your body's hypotensive and blood pressure is low, she's not perfusing, right? And if she doesn't perfuse, what eventually is gonna happen? Death. Okay, so first and foremost, hypotensive respiratory distress. So shock treatment, respiratory support may be needed if her conditions deteriorate. The heart does not function well with potassium levels out of line. We already talked about that before, right? Potassium has to be between 3.5 and 5.5, or 5.0, depending on what book you read. Okay, so if they're hyperkalemic, so elevated potassium, it's going to throw off her sodium potassium pump and cause arrhythmias. The heart does not function well. With the possibility of development of ventricular dysrhythmias, okay, they could go into VTAC and possibly even cardiac arrest. So vital signs should be monitored closely. These are your sick patients. These are your vital signs every 5 minutes. Get that 12 lead, put them on a 4 lead, monitor that, and look for the potential for ventricular tachycardia. At this point, okay, which intervention should you consider at this point, if any at all?
Fluid.
Okay, so IV access, right, and fluid administration. Now, if you don't feel very comfortable, remember, if you're giving too much, the reason why they're going for dialysis is they have too much fluid already on board, right? So do we want to give them 30 mLs per kilo?
No.
Not really, right? But I told you 30 mLs per kilo is for an adult. But what Lucas just did is he just became a clinician. He knows that dialysis, they can't filter out and they can't remove the excess fluid. So are we going to flood this patient? No. All right. So these are patients, even as an advanced EMT for fluid, call med control and consult with them and see what you really should be doing with this patient. Okay. Okay. We want to make sure the patient doesn't deteriorate into cardiac arrest. Let's go to part 3. You perform a physical exam on the patient while your partner prepares an IV setup. Your physical exam reveals the following findings: jugular vein distension, accessory muscle use, pitting edema of both lower extremities, and an area surrounding the shunt site on the right arm approximately 4 centimeters in diameter that is red, swollen, and hot to the touch. As you are completing your assessment, the patient begins to complain of a feeling lightheaded. You lower the head of the dialysis chair to a 60-degree angle, initiate an IV using an 18-gauge catheter in the left antecubital space, and after checking for pulmonary edema, you contact medical control but potential fluid administration. If the patient is taking on fluids they can't filter, the fluid has to go somewhere. Anytime you administer fluids or before you administer fluids, check lung sounds. All right. And as you're administering them, especially in a dialysis patient, every 200 mLs that go in, check lung sounds again. Make sure you're not flooding your patient and it's not being pushed into a spot that doesn't need to be. All right. So, is the patient going into shock? And if so, what type of shock are they going into?
Septic.
Okay. And I guess the answer would be yes. So the tachycardia and hypotension show the patient is going into shock, right? But which type of shock here can really be tricky, but you have to know those clinical presentations, right? Which Lucas said, septic shock is a possibility of the signs of infection at the shunt site. So we have fever, we have tachypnea, tachycardia, hypotension. I guarantee you with that blood pressure that the MAP is less than 64, okay? And there's redness, we have a known infection site, could be sepsis. With a history of a past MI, though, and congestive heart failure, you could also consider what other type of shock?
Cardiogenic.
Yeah, cardiogenic, right? You can't rule it out because it's still a possible cause. Additional electrolyte imbalances, especially hyperkalemia, may affect cardiac function. Hypovolemic shock may also play some role if too much fluid is removed too quickly during dialysis. All right, so that also could have happened where they pulled too much fluid off too fast and the patient can't recuperate, putting them into a hypovolemic shock. So what might IV fluid administration be appropriate, or why might IV for this setting? Why might IV fluid administration be appropriate? The main reason would be
Raise the blood pressure.
yeah, patient's hypotensive. Right, it's a common side effect of dialysis that can result in the change of fluid or electrolyte distribution. Right, if it's done too fast. So we have that ability to give fluids. Just make sure you reassess your patient's vital signs, lung sounds, and symptoms after any fluid administration. Like I said, don't give your bolus of 1,000, right? Or I should say your rapid infusion. Do 200, right? And the best way to do a bolus in a true bolus is draw it up in a syringe, a 60 ml syringe, and push it in. All right, that's a bolus. A bolus is not running your 15 drip set wide open, right? Unless you got like a 14 gauge catheter, and if you're doing that, you're just doing damage to a patient, right? But a true bolus is drop 200 mLs of fluid and push it in. That's a bolus. All right, almost there. Part number 4, and we'll finish up the night. You prepare the patient for transport, noting that her breathing is still labored. She tells you that she is less lightheaded after the first 100 mLs of saline has been administered. However, she still complains of being short of breath. You contact the hospital for further orders advising an estimated arrival time of 8 minutes. The emergency department physician has no further orders at this time. At the emergency department, you notice that the dialysis nurse is already preparing for Mrs. Jensen, prepping for Miss Jensen. The emergency room physician explains to you that the physical findings are compatible with early septic shock due to infection at the shunt site. Right? He also suspects that Mrs. Jensen's potassium level will be high because of the tall T waves of her EKG, fluid imbalance, either overload due to the missed dialysis treatments or relative hypovolemia if there was a drastic or rapid change during the dialysis performed. Could also be playing that type of role. So when you return to the emergency department that evening with another patient, you check up on Mrs. Jensen. She's resting comfortably in the medical intensive care unit, the MICU, where she is being treated for sepsis, congestive heart failure, and hyperkalemia, as her level is 6.7. After the day's experience, you decide that studying pathophysiology is an important part of your understanding of the disease process in your patients. So how did the inflammatory process manifest itself in this patient? Number 7, would you consider it being local or systemic or both?
Both.
Both.
Both, exactly. The local effects include development of redness, swelling, and tenderness and heat at the shunt site. Systemically, the inflammatory process was seen in the presence of a fever. So explain these symptoms, how these symptoms relate to the physiology of the inflammation process. Now we kind of went over a lot, right? So what's happening here? Well, actually, someone try to answer it first. Let's see if you get it right. How are we seeing edema? What happens with edema?
Retention of liquid or fluid.
Yep, causing the blood vessels to dilate and become what? Blood vessels dilate and then they become.
They damage, the cells are damaged.
Yeah, they start leaking, right?
Yeah.
Yeah, they become more permeable.
Yeah.
So, right, so they're causing fluid to enter the area and inflammation, edema, right? So the increased and slowed flow of the area due to the dilated vessels causes redness and localized warmth. So if vascular dilation and fluid loss to the tissue is sufficient, is sufficient, then blood pressure begins to drop with potential development of shock symptoms. Right. So then we start getting something called leukocytosis. All right. So leukocytes are now increased in number. Leukocytes being your white blood cells migrating through the vessels, vessel walls, attacking bacteria, and releasing pyrogens that cause fever. Right. So it's a big systemic response. Right. So we have this permeable blood vessels. We have edema. Now we have dilated vessels causing localized warmth. We know there's an infection there, right? Because of that, blood pressure is starting to drop. White blood cells, leukocytes are now being pulled to that area to say, we're going to stop that infection, right? And they start going to work attacking the vessel walls or through the vessel walls, sorry, attacking that bacteria and releasing pyrogens that cause fever. The body is heating up and now it's killing off that bacteria. Does that all make sense now? Having this understanding on pathophysiology is going to help you with your medication treatment and your treatment plan and the underlying cause of what you are doing. That turns you into that clinician, having that understanding of what is going on within the system. Okay. All right. Any questions on that at all? All right. Let me just turn off the recording really quick.